Good afternoon, ladies and gentlemen. My presentation consists of a number of slides which will explain the rationale for a proposal which is an integrated public health intervention economic recovery strategy. And this strategy, of course, involves the mitigation of the COVID-19 pandemic outbreak and epidemic in Jamaica. We gathered together a team of persons who we think would be able to put together a strategy that is in keeping with the circumstances and conditions of Jamaica and like countries within the Caribbean. The team consisted of yours truly, in the area of public health and health technology, Mr. Leo Williams, business and economic expert, Dr. Michelle Commission, aspects of research and development, Dr. Michelle Halliman, logistics and distribution expert, Dr. Donald Gordon, president of the Association of General Practitioners of Jamaica, and Professor Marvin Reed, president of the Caribbean College of Family Physicians, and of course, Dr. Marvin Reed also occupies the space as the head of the research unit at the University of the West Indies. A group of us started collaboration, and after a number of meetings, we demonstrated our methodology to Professor Marvin Reed and Dr. Donald Gordon, who became, and also to 117 physicians drawn from both organizations, who gave us not only the green light, but the approval with acclaim. It is at that point that we incorporated the professional leadership of these two organizations. What is an integrated public health economic recovery strategy? What is the theoretical basis for this particular strategy, given the unique circumstances and conditions which we face in Jamaica and the Caribbean? It is clear that we have to at least establish the theoretical framework within which we would begin to look at how we devise a strategy for Jamaica to recover from COVID, while at the same time preserving and enhancing its economic base. Caribbean countries do not have the luxury, nor the resources, to allow a situation which creates total meltdown of both its public health and economic systems. At the same time, we have unique and peculiar features which do not lend itself to solutions in the metropole. And so the first thing that we need to do was to at least look at the theoretical perspectives that we needed for an integrated system. Our first deliberation was to determine exactly what is the relationship between public health and the economy. COVID-19 is unique in all pandemics, and I don't need not to go over the history of pandemics globally. But it reminds us of the cholera epidemic in Jamaica after emancipation in 1948 to 1952, where we had two peaks of epidemics and we had to bury Jamaicans, massive amount of Jamaicans, in mass graves. Such a pandemic will not, manifestation of a pandemic will not obtain in Jamaica. because our knowledge and the resources and the infrastructure that we have built up since 1852, when we buried the last person in a mass grave, we have built up a public health capacity which negates that possibility. And so when we see the real possibility manifested in the international media, we know that we have a challenge. There are 6 basic theoretical perspectives to an integrated system as we define it. The first fundamental principle is the adoption and implementation of the World Health Organization public health intervention strategies for COVID-19 pandemic in relation to controlling the disease at the local outbreak and epidemic stages. However, the second theoretical framework is that we have a point of departure from our colleagues in the metropole, in that the integration of standard public health intervention strategies with economic recovery strategies in real time is what we seek. And we seek it in real time to derive what we refer to as synergistic efficiencies and cost-benefit outcomes, and reversal of and at the same time, reversal of the downward economic and public health outcomes. Now, this seems ambitious. However, we will have to be ambitious in the Caribbean if we wish to overcome this particular malady. For the simple reason that for the first time we're seeing a pandemic in the world where public health measures are determining economic outcomes. The traditional perspective, theoretical perspective, is that it is the economic outcomes which determine public health development. And we see this vividly during the 1970s and 80s, when the IMF, in order to redefine our economic strategy, closed down our public health schools, closed down our nursing schools. And by 1983, after we had eradicated polio for 31 years, because we had nothing on the ground to deal with our immunizations of our children, we had an outbreak of poliomyelitis, again after 31 years. Now that paradigm seems to have reversed. And the new paradigm seems to be public health measures determining whether and how we increase our economic activities. But we in the Caribbean do not think that it's a zero-sum game, because we see the relationship between public health development and economic development as 2 sides of the same coin. They are inextricably linked. And it is against that background that we propose the theoretical foundation of working together in a systematic way to achieve a kind of synergistic, integrated approach to both the mitigation of the public health pandemic and the increase in economic activities. And so, our point of departure remains the fact that it is not one or the other, but both working together in an atmosphere and under conditions which give rise to a synergistic relationship. Thirdly, in order to do this, we have pulled on the strength of the Caribbean doctor. What is the strength of the Caribbean doctor? The training at the University of the West Indies since the 1940s, 50s has produced a doctor who is trained in the art of the clinical diagnostic skill of medicine. In other words, we do the clinical examination and we make a clinical diagnosis. And it is on the basis of the clinical diagnosis that we do the tests in the laboratory to confirm the clinical diagnosis. The paradigm today is that to control this particular disease, we do the tests, and if the test confirms it, then we proceed. And so we aren't able to afford the tests. In any case, we can't afford the mass testing of our people. And so we have to use our strengths, and that is to say, the clinical diagnosis and the introduction of the medic and our clinical expertise as the primary tool for making the diagnosis, and the laboratory measure as a secondary tool for controlling the diagnosis, for confirming the diagnosis. How do we wish to do this? We know that it cannot be done manually when you look at some of the data which I'm going to display to you. And so therefore we have to introduce such technologies that can complement the clinical diagnosis and give the physician the capacity to see many patients rapidly, while at the same time maintaining the rigor of clinical standards. And so the fourth is that we're rejecting the mass laboratory test as a primary and case defining system. We are ensuring that the integration of mass clinical artificial intelligence, the use of artificial intelligence, DocBot, what we call a DocBot, which is a doc robot, as a pre-diagnostic screening system, working together with the clinical medical telemedicine diagnostic case definition of the physician, a stratified system of testing as a secondary case definition confirmatory method. The fifth theoretical framework perspective is that we integrate fully the data that we derive from this method, that is artificial intelligence data, together with physicians' clinical assessment, putting together all of that in a data system that now is integrated into the National Epidemiological Command and Control COVID-19 system. And finally, the real-time integrated and judicious rollout of business categories under strict logistical command and control protocols linked in real time to standard World Health Organization epidemiological control measures. That well, not brief, but in detail, the content of our theoretical framework. This diagram is the only diagram that I'm going to put that reflects the summary of what obtains not only in the Caribbean, but also in Jamaica today. In Jamaica, you see that the rate of infection far exceeds 1, which means that if you look at the steep of the curve, that is where we are. We are in that phase of the community spread and the epidemic phase of this particular disease. If we adhere to normal methodology of the rich countries, we should have massive amounts of tests and testing material to try to the so-called method of lowering the rate of spread to below 1. In other words, less than 1. And as such, flattening the curve, so to speak. But we are on the exponential part of the curve in Jamaica. And as you know, not even the richest countries of the world have either the resources or the capacity to get tests to change the trajectory of this curve. And so therefore we cannot use that as the basis. Otherwise we'll be burying our heads in the sand and fooling ourselves that we have the resources in Jamaica and the Caribbean to deal with that. What we do know is that the tests is supposed to confirm the diagnosis. But we do know that our culture is that we have clinicians who are trained in diagnostic medicine in the main and do not use the test as the primary diagnostic tool. We use the clinical evaluation as the primary diagnostics tool, and the test being the confirmatory diagnostic tool. And so, when we see what is happening in the Caribbean, up to the time of the 21st of April, the total of 9,035 persons have been tested or have been diagnosed with COVID-19. But in Jamaica, we see where we have in Jamaica a total of 223 cases. But when we look at the curve, we see the exponential development of rapid spread. We also have identified the focal point of this curve, of this spread, being Kingston and St. Andrew, which is the densest part from a population standpoint of the country. But if you look on the right side of that curve and on the left side of that curve, you begin to see where the spread takes place. This is logical because most of the population on either side of Kingston, whether it is in St. Thomas or in St. Catherine, Clarendon, there are persons who work in Kingston and live in these areas. In other words, with Portmore in St. Catherine being the renowned area for persons who live what we refer to as a dormitory existence. But the movement of population from Kingston demonstrates that Kingston and St. Andrew is the focal point. The question is, what are we going to do about it? Bearing in mind the fact that we do not have the resources and the fact that, in fact, competition for the so-called laboratory tests is such that we are at the end of the line. And so, therefore, it is incumbent on us as part of the intellectual and professional resource of this country to at least strive to build a solution for the protection of our people and its economy from devastation. Now, we therefore attempt to look at the measures that we need to introduce the Jamaica Integrated Public Health and Economic Protocol for getting back to work safely. First of all, we have what is referred to as an artificial intelligent bot. And we have developed that bot as part of 17 years of R&D, research and development in this country. The bot is incidentally able to determine not only the disease, whether or not the person has COVID, but also is able to determine the risk or the presence of other diseases beside COVID. The patient can engage the bot freely, and the bot will decide through a pre-diagnosis whether the patient has the disease or not. But this is a pre-diagnosis, and the report from the bot then goes to the doctor, all remotely. And the doctor then notifies the patient and engages them in a video conferencing telemedicine encounter, at the end of which there is the diagnosis, the clinical diagnosis. And so the diagnosis is made as to whether the person does have the COVID or does not have the COVID, or the situation is equivocal. The bot and the patient and the doctor can also determine whether there are other diseases present and make that diagnosis. It is this interface between artificial intelligence and the clinical encounter which will determine that. Once that is determined, immediately that data is sent to the command center to another doctor. And during the process of artificial intelligence and clinical assessment, where the doctor makes a definitive diagnosis, what happens is that principles of confidentiality and privacy is maintained in the value chain. Once it goes to the command center, the patient's name is not revealed, but what is referred to as a GUID, Global Unique Identification ID, is established for each patient. The patients who do not have the disease and who are fit are now separated, and those patients might then go to become part of the economic activity of the firm. Now, when we look at the cost of the clinical assessment and the cost of the COVID tests, we see where the cost factor is somewhere in the region of 4 times the cost that we would have if we use the method of just using the laboratory tests alone. But in this situation, we are able to do both by using data from the clinical and from the bot and the telemedicine data from the doctor to enrich the data in the command center by giving the location and therefore the data for track and possible tracing. Which sectors do we see can begin by using this particular method, where we have an integrated system linking the development and restarting of business and our public health intervention measures? We see factories, banks, supermarkets, BPOs, the tourism industry, and we have 3 phases of large-scale employers, SMEs, and MMEs. We intend that this proposal can in fact restart under strict conditions based on the use of the bot and not only the bot, but using clinical methods. That is the synopsis of it, and we hope to begin to demonstrate this on Monday. Hopefully, you will see the value of using these methodologies, that is, an integration of artificial intelligent bot for screening, where the bot can screen thousands and thousands of patients, because we know that it is impossible to control this outbreak using manual measures. And so with the introduction of telemedicine, artificial intelligence, supervised and confirmed by the physician, and the two sources of physicians being Association of General Practitioners and Caribbean College of Physicians, we will be in a position not only to control this particular epidemic, but to prevent total blackout and deterioration of our economy. Thank you.